All right, y'all, if you've seen our videos before, you know the drill. I'm Erica Belofsky, Community Outreach Specialist with HD Reach, and I am here with my co-host from Help for HD,
Lauren Holder.
and we are continuing our Rare Topics for a Rare Disease theme with diving into sex, intimacy, and HD. Do you have questions about whether HD impacts sex drive? Can love languages change over time? Are you having difficulty opening up communication around sex? This webinar is for you. We are absolutely honored to have Dr. Karen Anderson, psychiatrist and director of MedStar Georgetown University Hospital's Huntington's Disease Clinic. What a mouthful, in Washington, D.C., which is also an HDSA Center of Excellence. She's here to provide her professional insight into this topic, along with me and Lauren. Dr. Anderson, would you like to talk a little bit about yourself before we get started?
Yes, thank you so much, Erica and Lauren, for having me here today. I am a psychiatrist. As you mentioned, I specialize in movement disorders, which means I also see people with Parkinson's disease, Lewy body dementia, Tourette's, and other neurological conditions. But really, the focus of my clinical work and almost all of my research is in Huntington's disease. And I've been working in Huntington's disease since the mid-1990s. I've been involved in clinical trials in Huntington's disease and also in creating statements and guidelines on care of psychiatric symptoms in Huntington's disease, and also have helped develop an online platform for research in Huntington's disease with the Huntington study group called My HD Story.
All wonderful things. What is keeping you in this community and continuing to do the great work you do?
You know, Huntington's is so interesting as a rare disease. I feel like as a psychiatrist, there's so much need. I mean, there's so much need in many of the populations I've seen, the Parkinson's patients, I've worked with Alzheimer's patients, but in Huntington's, there's a particular need. It's a neurological disease, so a lot of the care is provided by neurologists, and there are terrific neurologists working in HD who absolutely understand behavioral issues. But I feel like as a psychiatrist, I can bring a different perspective to care, and I can provide interventions that can make a tremendous difference to patients and families while we're waiting for these clinical trials to have a hit for something that slows disease progression.
Absolutely, absolutely. I think we can all be on that team of the many different specialties that Huntington's disease patients need and require, and just the community in general, and especially during this time where we're waiting and hoping for something that slows, that pauses, that something good in the future that I know we're aiming towards. So back to our topic of sex and HD. What happens between sex drive and sex and HD? Like, do you get asked a lot of these questions about by your patients very much, like in clinic?
I have to say that I don't get asked a lot in clinic. These are the kind of questions that I get asked sometimes in the hallway between clinic visits, or if I'm at a patient forum, someone might pull me aside, or if there's an opportunity when I'm giving a presentation to ask anonymous questions, like people can write questions down and not put their name on the question. That's often where I get these questions. I think, unfortunately, we don't ask about them in clinic enough. And I think that a lot of practitioners might not be comfortable talking about sex and changes in sexual relationships with disease, but it's obviously a huge issue for our patients and families, and something that we definitely should be talking about more.
Yeah, I totally agree. This is one of the reasons that we say it's a taboo topic in HD, just because it's not something that we talk about really anytime. So I am really excited about today and getting to delve into this and kind of open a door, hopefully, for the community to be able to start talking about it.
Yeah, I guess, how do we change that? Like, I know as a society, talking about sex has become more and more, a little more common than historically it has been, but there's still that discomfort. I guess, is it kind of bringing it up to your doctor earlier? Like, would that make a difference? Would adding it to an assessment make a difference? Or does it, do you want to build on the relationship first?
I think building on the relationship for something like this is really important. I think bringing it up early or asking early, particularly if you have concerns that aren't yet a big problem, it's wonderful to ask early so that your provider has a little time maybe to make a referral or chat with some colleagues informally, and get more information for you, because not all providers are going to be prepared in the middle of clinic to suddenly give you advice on your specific question about sexual dysfunction or sex drive or change in relationships. So I think asking early, thinking about it early, maybe setting up a separate time outside of clinic to talk with one of your providers can be very helpful also. And then obviously forums like this where we bring it up and make people aware that it's something that can be part of HD and it's absolutely fine to ask about it.
Mhm.
I think there's several different layers to this topic. So obviously, a lot of times in the community, we hear about hypersexuality. And I really love to hear kind of you describe what that is so everybody knows. And then the other thing that we don't hear about that often, and you kind of mentioned sexual dysfunction, but being asexual and not having an interest can also happen in HD. And could you just explain the difference between those two really quick?
Of course. So hypersexuality in some ways is in the eye of the beholder, right? A lot of these psychiatric symptoms are in the eye of the beholder. So if you have two people who've been in a relationship and maybe one of them has never been as interested in sex, or maybe they were both had about the same level of interest and suddenly one has way more interest than he or she used to, that can be viewed as hypersexuality. Um, and it can just be a natural change in a relationship because things change over time for people who are together for many years. Or it can be Huntington's disease, maybe making someone more impulsive, more likely to act on a thought or talk about something in ways that just might not have been characteristic before. So part of it, part of the question, if someone asks me about this, is what was the baseline like before? Was this always somebody who talked pretty openly about sex, or is this somebody who was really conservative, someone who really, would not mention something about sex at all to anyone else, maybe not even their partner, right? That's the first question. And then, hypersexuality, is it a problem? Is it something where someone's just more interested in talking about it more and the partner can adjust to that and it's okay? Or is it embarrassing? Is it inappropriate because someone's talking about sex in front of young children? Is it embarrassing because when you go to church, suddenly the partner's talking about sex at church and it's just not the right setting? Or is it, really aggressive sexuality where someone's demanding sex more than the partner wants or becoming very aggressive to the point where it's uncomfortable or even unsafe for the partner? So, that's a part of hypersexuality. Another part of it can be someone who starts to look for sex outside of a monogamous relationship, right? Somebody who becomes interested in sex with lots of other people. And this can happen in HD where somebody becomes impulsive and, decides to look for sex with other people. And again, it kind of depends on the relationship as to whether or not that's a problem or not. So the flip side of that, which is actually something that I hear about more commonly, is hyposexuality or asexuality, where someone's just not as interested in sex. So again, it may be where there is a certain baseline and then things just kind of go down where someone's just not talking about sex, not initiating sex, not as interested in sex as he or she used to be. Sometimes in a relationship, that's fine. Things adjust and it's fine. And sometimes it's not, where the partner who doesn't have HD may feel very abandoned or feel, very sad that this has changed in the relationship. So those are kind of the two sides of sexuality in HD. The challenging thing is, as I said, relationships change over time, right? So people can just change whether or not they have HD. Interest in sex can kind of go up and down depending on how much time someone has, whether there are small children running around the house making demands on everyone else, whether everything else is stable, like there's shelter and stable food, stable employment. All of those can be real factors with this.
And what I'm hearing, and I love that you say that before all this, you're like, it's kind of in the eye of the beholder, where you're going, you're acknowledging that everyone has their own different levels of intimacy and sexual drive and sexual history. And just because your situation is a little bit different than somebody else's does not mean it's necessarily wrong. It's understanding what is comfortable, or what you're learning about each other, what you're communicating, what you're figuring out is comfortable for you as a couple.
Exactly.
Since we were on the topic of hypersexuality, I know you mentioned somebody might be looking out for other sexual partners. I know historically, what I've heard from some people, that it's put them into some pretty difficult situations where there is sexual exploitation. Can you talk a little bit more about that and what you can do to kind of try to seek help for yourself and your loved one?
Right. So if somebody is making choices that are unsafe, again, sometimes this is in the eye of the beholder, right? So this may be, someone's from a very conservative family and it's felt that it's not appropriate to have 2 or 3 sexual partners. Is that really unsafe or not? That may be something of a judgment call. But I think some of the more extreme situations I've seen where people are, perhaps meeting sexual partners on dating apps, meeting people in places where it's not safe, meeting strangers from the internet, situations like this. It may be that the family really has to pull in help from their clinical team to discuss, is this behavior within the bounds of normal? Is this behavior something that's going to put someone at risk of getting an unwanted pregnancy or a sexually transmitted disease, or being, assaulted or taken advantage of in another way? And depending on the stage of disease, is this person's judgment so bad that he or she can no longer make these choices anymore, right? Does the phone need to be taken away? Do the dating apps need to be stopped? Does a credit card need to be turned off so that someone can't pay for sex, for example? Those are the types of interventions that we sometimes have to talk about, unfortunately.
Also talk a little bit about, because I think this is also really common when we talk about like the hyposexual side of things, and just like dealing with embarrassment, right? Like if you are having a hard time with intimacy and sex as a person with HD, like you're embarrassed because of movements or you're embarrassed because of something else, and how you kind of deal with those symptoms, because you still want to have that intimacy with your loved one, but you're struggling to get over those feelings of embarrassment or shame or whatever.
That's a really great question. And this is one of those situations where your clinician in clinic may not be able to help you right on the spot. But if you let him or her know a little bit early, this is a perfect situation where a marital counselor could be really helpful in just providing a safe place for 2 people to talk about this. So it may just be a matter of somebody who has HD symptoms being able to say to her partner, look, I have movements. I don't know what you think about that. Is that upsetting to you? I would be upset if someone had movements when I was trying to be intimate with them. And then maybe the partner actually is fine with it. These things, the movements tend to change pretty gradually, so people can adapt over time, and something that might have been shocking or unusual, if it happens suddenly, when it happens gradually, sometimes it's actually not such a big deal to people. The other issue that sometimes comes up is if somebody has neurological symptoms, they have movements, maybe they have some difficulty speaking, can they still give consent for sex, right? Is that something where are you as a partner, as a spouse, taking advantage of someone? And I think it's again important to think about, people don't lose the ability to consent to things. They don't lose the ability to make judgments of their own necessarily just because they have HD. So someone who's not able to push a vacuum cleaner around, or maybe not able to drive a car, may still be perfectly able to tell you, yes, I'm interested in having sex, I want to have sex, or no, I'm not interested in this. This is not something I want to do right now. So people should be able to express their preferences, unless they're making really bad choices that are really unsafe.
Yeah, because apathy is a very big proponent of Huntington's disease. It's a symptom, and so I can understand how that would be really difficult if you have somebody who is apathetic. And despite verbalizing being okay with it, as a caregiver, I would almost be like, but the apathy is so apparent, so strong, I don't feel like you're comfortable. And almost like stomping on their desires, their needs and wants, because I myself am uncomfortable with this symptom of Huntington's disease, if that makes sense.
It does. And I think it's important to remember that, apathy is really a spectrum. So you can have a little apathy, you can have a lot of apathy. A lot of people with HD who have apathy may not be able to start something. So they may not be the one who reaches out and holds someone's hand or starts to give a kiss, but they might really enjoy something once they're in it. So just because someone is not, actively initiating sex doesn't mean they won't enjoy it once they're in it, as long as they're able to give consent and say, this is something I want to do.
So it's going back to that communication between the partners and expressing consent, expressing feeling and comfortability to reach that level where they both are satisfied in their own way.
Yeah, exactly.
I think you just said something too that I didn't know, that apathy is a spectrum. Like not realizing that it is a spectrum. So it's not that somebody completely shuts off or anything like that. And I think that's a really important thing to remember as well, that, as you said, it's a spectrum. So I just never thought of it that way.
Right. So on one end of the apathy spectrum, you have, the people we think about, usually they're later stage HD, who will sit all day long. Maybe the TV's turned off and they'll sit on the couch and look at a blank TV screen all day. They're not sad, they're not suffering, they just don't care, right? That's the severe apathy that we think about. But on the beginning part of apathy, there are the people who get up, they take a shower, they eat their meals, they may go to work, but they don't necessarily have the initiative to do a hobby. So if they used to enjoy crocheting and they're still able to do it, they have no problem doing it physically, but they just don't have the initiative to get into it, right? And that would be very early apathy. And then apathy would be in the middle, would be people who they can get up and they can get themselves dressed, but it's a challenge. And maybe someone else has to kind of encourage them to do it, but they'll still do it on their own, right?
Thank you for sharing that. That's really interesting and not something I ever thought about. And I think another big thing that, at least what Erica and I have talked about before, are love languages. And, there's this idea of love languages and what happens if love languages are not filled, and, dealing with that. And because I think that's really hard sometimes, especially on caregivers, where if their love language is intimacy and they can't get that any longer, it's really hard for them to provide the love language for their loved one. And, how do you deal with that? So I'm really curious to hear kind of your thoughts on that.
And that's again something that's pretty individualized. So does it mean that the way that you express caring changes? Do you communicate it differently? So if you have trouble speaking, does it mean that you rely more on touch and on gestures to show that you care about someone? And as a caregiver, does it mean that you seek intimacy outside of that relationship? So I certainly know caregivers who've had relationships, outside of their marriages, for example, because they're just not getting the fulfillment that they need from someone with HD, even though they continue to be really devoted, wonderful caregivers. They love that person, but there is just something missing, usually in the later stages of the disease.
And I mean, as a person, with HD, for years now, I've been married almost 20 years, and it'll be 19 years in October. And
Congratulations.
Thank you.
Yeah.
But I have absolutely had that discussion with my husband, because, I sit there and think to myself, if I'm symptomatic and I'm not able to provide, to meet those needs, is it something that I would be willing to, make sure that he could get those needs met to make his life easier, and also to have the support he needs, if I'm advanced stages and can't do it. So I think those are conversations too that tie into this, because we are in a day and age where it's not necessarily looked down upon and something that you have to hide. And I think that's important also to have those discussions early when you're at a point where, you know, you're not dealing with symptoms. Like, go ahead and have those discussions if you know that's what your future is going to hold, because things change, and it doesn't mean that, you know, the person loves you any less, but you can also know like their needs not being met and understand that. So I think that all ties into this discussion and is really important to actually mention, since it's this taboo topic.
Absolutely. Yeah.
Yeah, and I as a at-risk individual also have had those conversations as well with my partner of going, you know, if this was something that happened in the future, you know, our love language change and adjust over time, and you know, what would that look like, and you know, permission and this and that. And I mean, I think it was a great conversation where, I mean, we're very content in what we have, but we haven't been put in that situation yet. But it's kind of opening up that language of, let's just talk about the what ifs. Like, even if it's not HD, like at some point, you know, there might be a caregiving role in the future as we get older, as we, you know, as there's illnesses out there. But love languages and the different forms of intimacy, hand holding, gift giving, you know, being able to do something for somebody, or, you know, doing the dishes. Like there's so many different forms that will adjust and change over time, but how will we adjust and change together with that? So I'm big proponent of communication, and I know it's so difficult to do that because it's, some people, communication is not their strong suit, which is okay. I think we're moving forward where we're like, let's talk about feelings and let's really try to crack this open and really start talking. But there's still generations where that's just not part of their DNA.
Right.
So I hope a video like this is for that person who really feels uncomfortable or is experiencing some of these things, going, is this HD? Is this, you know, this and that? And hearing that their situation is not new, it's not different, and it can be explored and supported.
Yeah, and I think Dr. Anderson also brought up something that it was kind of a starting point, like go to marriage counseling. This is something that they, you know, that would be a place to start. We actually, you know, Erica and I had talked about, you know, having a sex therapist come on and talk about kind of what they do. So there are options of people. You don't have to just go to your neurologist, you know, if you're not comfortable with that. I think that it's a great starting point to be able to get a referral and things, but there are things like marriage counseling and sex therapists and things that can absolutely help.
There are medical sex therapists, like for medical needs, which is
right.
You know, it's amazing that there are these kinds of options, even though they're smaller. You know, they're not as common where you have them. You may or may not have the support within your state, but that's a real thing.
That's such a good point, Erica, because you're probably not going to find a couples therapist who has HD experience. Maybe you'll hit the jackpot and you will, but unlikely because it's a rare disease. But if your treatment team has a little time to think about it and make some calls, there's probably someone who's worked with cancer patients, Parkinson's patients, families with Alzheimer's disease. So there's probably someone who's worked with caregiving issues in a marriage and, you know, has experience with that. And that's usually the best starting point. And then, you know, getting your own center psychiatrist or social worker in touch with a therapist just to see, you know, are there particular things about HD that, you know, he or she might need to know a bit more about.
Can HD cause changes in sexual attraction or sexual identity?
In terms of sexual attraction, I mean, we addressed that a little bit with hypersexuality, right? Where somebody, you know, who'd formerly been monogamous might start to be interested in a lot of other people. I cannot say that I've had a lot of experience with HD changing sexual identity. So for example, somebody who'd been homosexual suddenly deciding they're heterosexual after getting HD. I have not had that experience. I think, again, if it makes people a bit disinhibited, it can make them open to other experiences. So sometimes, someone may start using pornography just because it's something they may have always done, but they kept it hidden, or something that they've always wanted to do. And now they're less inhibited about it. But I can't say that I've seen it really change sexual identity in someone.
What about advanced stage HD and dealing with sexuality? Like, is it still an issue in advanced stages?
It definitely is. There are people who, many people with advanced HD have apathy, so it becomes less of an issue for the patient because the sex drive just sort of decreases as the apathy progresses. But some people have, pretty active sex drive even through the end of the disease. When the person is at home, that can be managed a little more easily by providing pornography, for example. So if somebody wants to masturbate and they have a private place to do that and they have pornography available, that might be something that can be done at home if the family is comfortable with that. It can be a bigger issue in long-term care, particularly because people often share rooms in long-term care. So a roommate may not be particularly happy about having someone masturbate in the room. So sometimes it's a question of, is there a private place where someone can go to do that? But that is a good question, because not everyone loses their sex drive as HD progresses.
What about physically, like physical changes within like climaxing and, are there certain things that just the brain eventually cannot process and do, or is that really on a personal level? And what can caregivers do to kind of monitor that? And
it really depends on the person, right? So some people, again, it's mostly through loss of interest. Some people just may not climax because they're just not interested. They might still participate in sex and enjoy it. It's just different for them. Other people may get frustrated. So they may get very frustrated if they're in a sexual experience and they can't climax. So then, it's important for the caregiver to notice that and try to work with them on that. Again, maybe if there's a less pressured situation, like masturbating alone rather than having sex, somebody might be able to still achieve climax doing that. Sometimes people will get performance anxiety if they have trouble with a partner a couple of times. So those are definitely things. In terms of physical safety, you do have to think about that a little bit. If someone has a lot of movements, whether it's going to be safe or if someone's going to harm themselves unintentionally with the movements or harm their partner, certainly.
So, okay, I have another question, and I don't think it's on here. So we're talking about adult HD, but what about JHD? Do they still deal with all of that as well? I would imagine, in the teenage years, that's really hard.
It is really hard. And it can be really hard when you have a parent who's taking care of you instead of your spouse, and you have sexual desires and you don't necessarily have a partner with whom you can act on them. And you may not have a parent who's okay with you masturbating in the house. This kind of goes back again to, can somebody be alone in private to do this, or do they need such constant supervision that they just can't? But yes, that can be a big deal in juvenile HD.
It's a great question, Lauren, because I know we've all been teenagers, but we have not been teenagers who have experienced juvenile Huntington's disease. Right. To have the puberty, to have the different feelings and emotions, and not having the lack of, not being able to restrain ourselves or sending out the messages. I know that's been a difficult thing for some parents, for their child sending out messages, and it's just, it's just the stage that they're in right now. Does that typically, do you see that to be a temporary stage where they might have a, moment where they're sending out messages, they're constantly trying to get attention from somebody, and then it mellows out, or is it usually treated with medication?
It might be treated with medication. It might be treated by taking the phone away or limiting the apps that are on the phone, or getting rid of a smartphone and just having an old-fashioned phone if there's a need for a phone for some reason. Because this is, somewhere with the apps that safety can really become an issue.
Absolutely, I agree. That's opened up a whole new world. Technology is great, but It's the avenue for a lot of bad things.
It is. It's great because people can find companionship even if they're homebound. They can find entire communities, right? It can be wonderful, but it can also open people to predators or others who just don't understand HD and may not realize what they're getting into.
Thank you, Dr. Anderson. Lauren, do you have anything else that?
I don't. I find it all
Like,
very interesting, and I'm so glad like we talked about this. Again, this is just something that we've wanted to talk about, and we were trying to figure out the way to do it, and I think this was perfect to just have this conversation, and I had a lot of questions answered and learned quite a bit today. So thank you so much, Dr. Anderson.
Thank you. And thank you for recognizing this as a topic for HD families. I think it really is important to at least start the discussion so that people know it's okay to ask about it. It's okay to talk about it at clinic visits, and it's definitely okay to talk about it within the family.
Sexual health and wellness is a part of life. It's despite, I know religion, cultural, there's a lot of complexities that get added to it. But hopefully somebody within the privacy of their own room can look at this video, and this can give them some information, some guidance to at least start thinking about talking about this and bringing this to the forefront of this is very, very important. This is happiness. This is, and this is normalizing that this is a natural part of life.
Definitely.
Yeah, and I really just hope it starts to open up those conversations because again, we it's not something we talk about. So I think that being able to show like a person with HD just because they're symptomatic doesn't mean that they don't want to be intimate. That part's not gone. It's still there. But the caregiver may have to initiate more. That's a huge thing. And the person with HD not feeling guilty or embarrassed over their symptoms. That's a huge deal because I think that for some reason there's always been this embarrassment and shame and stuff when it comes to symptoms of HD, and it doesn't need to be there. So I'm really hoping that other people can really take from this and not be afraid to have the conversations with their loved ones.
And include their care team if they feel, if they want that extra support as well. And if for some reason the care team is not supporting them in the ways that you need to, like we said, medical sex therapists, like look into some other like clinics, like it's a topic that deserves to be talked about. You deserve to feel safe and comfortable in talking about it.
Yeah, absolutely.
And there are people that are out there that can have that conversation with you.
Yep, absolutely.
So thank you again for Dr. Anderson for being on here with us. And anybody watching this webinar, if you have any questions, you have anything that you want to ask us, you can check us out at www.hdreach.org. Maybe we'll connect you with Dr. Anderson. Maybe we'll connect you with somebody local to yourself. That's what we do here at HD Reach, is connect you to your local clinics, your resources. And thank you for being with us.